name is Sarah Hopkins. I'm the head of the section for MS and neuroinflammatory disorders at the Children's Hospital of Philadelphia. And I'm going to talk about something I've never done a talk on before. And that's counseling for caregivers at the time of the AFM diagnosis. And we're actually going to go a little bit beyond that. I was lucky to be able to attend the family camp for the Siegel Rare Neuroimmune Association that was at the end of July, the beginning of August, and able to talk to some families of children with AFM and other rare neuroimmune conditions and kind of get some ideas from them about what they would like to have known up front, or maybe what they wouldn't like to have known up front. And so those are incorporated into this, as well as some of my own experiences in talking with our families here at CHOP. So I do receive salary support from the CDC related to AFM surveillance, and also in the site PI for the NIH AFM Natural History Study, and we'll be discussing the off-label use of medicines. The first thing that I wanted to talk about was that there are ways to set yourself up for success in terms of talking with families and ways that you can gather more information right when the family initially presents with a concern about weakness. So one of those things is to build a team. So to have a team of people that are more interested in the diagnosis. You don't all need to be experts. But really just that interest in finding out more and providing the best care is really key. One thing I heard again and again from families is that they feel like they sometimes go to providers and they don't have any idea about AFM, and they have to educate the provider before they can get care. So I think it really is important to have an idea who the key people are that have an interest in your facility, in your region, and be able to incorporate those people into care for these patients. And important to recognize, like we've talked about several times already, that early recognition and diagnosis is helpful. And that involves being sure your frontline providers are watching really closely for AFM and that they're actually looking for weakness. So Dr. Otten showed this PDF from the CDC, and I think it really is helpful because a lot of times in the acute care setting, sometimes, grip strength might be checked, but putting hands over the head isn't checked. So you want to make sure all your patients can do a high five and that they can stoop and recover, and that all of your frontline providers are aware to test for those things too. The other thing is that early testing for associated infections might actually be able to help us talk a little bit with the family about prognosis. So we think that our patients with enterovirus D68 may be more likely to have significant sequelae than, say, enterovirus A71, which is more commonly associated with a rhomboencephalitis. And if it is associated with AFM, may have less residual weakness. Although everybody's going to be different, it's not absolute. Testing for AFM as soon as that diagnosis is suspected is really essential. You heard from Adriana that we only get positive respiratory viral samples in about 40 some of the patients reported to CDC with AFM. And the earlier we can test, the more likely those are to be positive. And it might help you talk about prognosis with the families. And, the other thing is, you might test in somebody who turns out to have something else going on. They have a brachial neuritis or a toxic synovitis, but all you've done is a respiratory swab. So really not the end of the world. And we also want to maximize potential for early treatment. We'll talk a little bit next week about some potential ongoing research. There might be clinical trials that come out at some point. Important to be able to recognize those patients early on and potentially get them treated. The other thing is, if you look at the mouse models for IVIG, if IVIG were going to work in acute flaccid myelitis by improving humoral immunity, it would have to be given really early. And frankly, we often don't give it that early because the patient comes in, maybe they go home because they're not diagnosed, they come back, an MRI gets ordered, but then it might take a day or two because of sedation needs, depending on the situation. And then by the time the IVIG or whatever treatment is ordered, it might be actually several days into the process. So really trying to plan ahead, maximize the potential for early treatment with the team at your facility is really important. And then, of course, being aware of ongoing studies to help families in the future. If you have questions about initial evaluation of AFM, the CDC website is a great place to look, and you can find copies of this PDF that you can actually share with other providers at your institution as well. So when first discussing things with families, I do think it's important to acknowledge that there are uncertainties in diagnosis and medical treatment. Those of us who take care of an awful lot of patients with AFM aren't always sure that that's the diagnosis when we first see the patient. I mean, frankly, it's much easier in an outbreak year, right? Because those patients tend to have classic AFM, but especially in the off years, it may or may not be AFM or TM or MOG or neuromyelitis optica. And the imaging can have a lot of overlap, as we already heard from Dr. Kralik. So I have two cross sections of MRIs on this slide, and one has one has MOG, has NMO spectrum disorder related to MOGAD, and then the other one has AFM. And I would submit that just by looking at their images, you wouldn't know who had what. So it is, I think, important to review the images with the family so they understand, where the injury is and why that causes the clinical picture with AFM. And then discussing options for treatment and the reasons for initial choices as well as next steps. One thing that's definitely true is families do tend to talk to each other once they get hooked in. So the question may come up, why didn't my child get this therapy? Why did they get that instead? Why didn't we consider this? So I think it's important to be very clear about why you're making whatever the choice is for treatment, knowing that at this point there have been no clinical trials in AFM, and that there is some ambiguity about the best therapy. We also want to be sure to discuss goals of medical treatment at the beginning. So most of our medicines, we are giving them to hopefully try to minimize the progression of AFM, especially with IVIG. We don't necessarily see patients with the gray matter injury of AFM getting better immediately when we give them a medical therapy. So that improvement comes over time with focused therapies, focused rehab. And I think it's important for families to have an awareness of that up front, that they might get some better with medical treatment in the hospital, but it may be that it's longer term PTOT rehab where they really see the improvements. The other thing we want to do when we first meet a family with AFM is to discuss the short-term risks up front. As Dr. Riggs mentioned, we definitely see potential for worsening over the first few days after a patient presents with AFM. And this risk for deterioration means that ICU transfer and respiratory support may be needed. It may also mean that you immediately admit a patient with a high cervical lesion to the ICU because you're aware that respiratory support may be needed. And the family needs to be aware of that, because acute respiratory deterioration is scary for the families, especially when they don't understand what's going on. And we already talked about, treatments that are given may not dramatically improve the weakness, and functional improvement comes over time. So preparing that, at least in the next few weeks to months, things are going to be a little different. There are going to be a lot of appointments. There's going to be a lot of therapy. Things like that. What will the future be like? And early discussions with the family, it is, I think, important to recognize that there is definitely a grieving process. So families are starting to realize that life may be different at this point, and people will be ready to discuss long-term prognosis at different times. And it may be well into the admission before they want to talk about that. So if it's not clear what they would want to discuss, absolutely ask them, how much do you want to know? What are you thinking? What are your main questions? Easiest I think to involve social work early on and make sure that you're giving families plenty of space to talk about things and to check back often because questions come up. Ask them to keep a list of their questions so that you can keep up with that. And make families aware that there will be a lot of medical care. And then recovering from AFM is hard work, even for the children that recover well. I think part of that learning what to expect is making sure that we're providing resources, both for families and for other clinicians. One great source of information is the Siegel Rare Neuroimmune Association. That's their website there. In particular, Rebecca Whitney, who is helpful in discussions for this presentation as well. And she told me that I could give you her email and her phone number. So there they are. Rebecca is fabulous at talking to patients, answering questions, helping them know what to expect, and also in linking families to each other and to support groups, and also that SRNA family camp that I told you about. Families also told me that it would be nice sometimes to have written information up front, and often that doesn't happen when you come into the hospital at first about diagnoses that are suspected. The SRNA does have a nice AFM fact and resource sheet that is at that third link there. And it's great to give to families. It gives them some websites that they can look at later when they're ready. And also some resources. So the Acute Flaccid Myelitis Association is an association founded by families. So again, it's another way for families with new diagnoses to reach out. Another thing that the Acute Flaccid Myelitis Association does is that's a potential source for small grants for funding things like equipment for families if there are needs. And then, of course, the CDC website. So there's a specific webpage for parents, and there's also a page for clinicians and health departments. One thing we often don't think of, kind of as much as we should, or don't talk about it as much, is that everything has changed also for these children. They're suddenly unable to use an arm or unable to walk, and it's scary in the hospital, and there's a lot going on. So important to remember to provide psychological support for the child. And this may be pretty institution dependent. We have a program designed specifically to help kids with new neurologic diagnoses adjust from a psychological standpoint. Other things that can help are opportunities to meet other children with AFM or spinal cord disorders if they want to. And especially for older children, allowing them, with discussion with their parents to participate in decision making as well. Building a little bit of autonomy, building confidence that they can start to learn to work through their medical diagnosis, and to give them a sense of control over the situation. Also important to ask kids what they want to be able to do. There are many adaptive options for gaming and sports, and here we have an occupational therapist whose entire specialty is adaptive gaming. So making sure that kids with AFM and other disorders can participate in the games that they want to play. One additional thing I wanted to mention is this new book sponsored by the CDC and the SRNA called No Time for the Moon. It's specifically geared towards children with AFM and talks about kids with differing levels of disability. It's really a delightful little book, and I would encourage you to take a look. You can find the PDF at either of these websites, and then at the We are SRNA website. You can also find a YouTube video. I was going to include it in my presentation, but I was afraid it wouldn't show up very well. But it's really a neat book. You can print it for families. There's a section about AFM resources for parents and helping children through this time. And there's also a way to request a hard copy of the book. Other things about long-term discussions that may occur later in the hospital stay or early kind of in a rehab stay. So important to remember that a diagnosis of AFM is life-changing for families, and frankly that they're aware of that as well. That long-term there can be persistent weakness. Function does improve over time. Early and continued rehabilitation medicine consultation, PTOT, speech, considering eSTIM and other therapies. A lot of my patients really do well with aqua therapy. And also for them to know that there are surgical options that we sometimes need to explore if we're not getting the improvement that we like or the improvement that we want with therapies. And those would include nerve and tendon transfer surgeries. One additional thing I would say is if the improvement plateaus, don't be afraid to seek other opinions. One thing that we see sometimes is that children with AFM sometimes may plateau a little bit for a period of time, or so they plateau, they make improvements and then plateau. And then sometimes a therapist will say, oh, you know, we're plateaued, we don't need therapy anymore, and then they'll stop therapy, and then things may gradually get worse. So typically important to be sure that families are continuing to check in with their therapist, their rehab doc, their neurologist, just to be sure that we're continuing to move things in the right direction when at all possible. And really the data seem to be that we can see continued improvement in strength, and even more than strength and function, even months to years after the initial diagnosis. Also, parents do say that a heads up about long-term complications early on can be helpful. And of course, you don't need to talk about every potential eventuality, but maybe talking about bone density, possibilities of scoliosis, limb length discrepancy, joint subluxation, things like that. And also, again, important to really have involved a rehabilitation medicine specialist at this point to be sure that some of those things are watched for closely. In terms of resources for providers, if you have a patient with AFM and you're stuck with a particular question or need more information, there are a couple of solutions that are available for you as well. One is this SRNA physician support portal, so you can talk to a neurologist with expertise in AFM, either Johns Hopkins or UT Southwestern, by clicking that link and filling out that form. The Acute Flaccid Myelitis Working Group, this website is particularly nice because in the resources for healthcare providers, there is a list of papers with links to the PubMed for those papers, and many of them are available online free. In particular, the recent review led by Dr. Olwen Murphy that was in the Lancet in 2020. That's a really nice comprehensive paper, I think, for making sure that you've checked off all the boxes in terms of caring for your patient with AFM. And then also wanted to share that we do have a clinical pathway at CHOP for the evaluation of suspected acute flaccid myelitis. And the link is there if that's helpful to you. Other suggestions that families mentioned, I think I did already say, so providing things to read when they're ready. So giving some resources, giving some good websites so that they're sure they're reading reliable information. Providing consistent support, and of course that's easier if you've got a team of people with an interest in AFM, so the team can check in regularly and they know, from the get-go, these are my people. This is who I go to when I have questions or issues. Having a team familiar with AFM helps, and that includes transition to adult care. So if you can help them identify an adult provider who has an interest in AFM and is aware of the potential complications that are involved, that's helpful as well. And then the one thing that families really especially wanted other families to know is that life is different, and it may not be what they expected after their child has AFM, but there's still a lot of beauty in it, and there's still a lot to love, and that's part of our job to help them get to that place. So I want to thank the Seagull Neuroimmune Association, especially the families at camp, and Rebecca and the AFM working group, and my CHOP myelitis and myelopathy team. And happy to answer any questions if there are any at this point.
Thank you, Sarah. That was fantastic. Thank you so much for that presentation. I think that one of the things that you mentioned at the beginning was the team effort, and frequently neurologists and pediatricians are basically involved at the beginning, but there are other people that need to be involved. Do you mind expanding a little bit again on the need to bring many of our colleagues in rehab and ID, and what is the importance of that?
Yeah, so I think it really is important to have a team. You know, we know that, well, I think it's really interesting that in polio, one of the recommendations a long time ago for polio was actually to hold off on starting rehab, PTOT, and things like that until after the acute illness period. But we really are finding in AFM that the earlier we involve PT, OT, and rehab, the better. You know, you don't want to have as much muscle wasting. You want, you know, even if they do have residual weakness, you want more to be there to work with in the event that, you know, your patient might need nerve transfer surgery, or your patient might need tendon transfer surgery or some other procedure. So important to involve rehab, PT, and OT up front. Also important to involve your infectious disease doctors, and I would argue potentially even more important now that there's concern about the reemergence of polio in the US. And also, again, social workers, psychology. I don't think you can underestimate the benefit of being sure that your patient's mental health and their family's mental health is in the best place that it can be in this situation. Am I forgetting somebody, Carlos?
No, actually, it's great. And I always emphasize that when we are dealing with these patients in the intensive care unit, there is always the need for helping the family, the parents. I mean, it's not only the patient, it's the parents and the family members that are under a lot of stress. And they like to get the answers very quickly, and we may need to be very transparent about what we are observing and dealing with. So this is very helpful.
Yeah, I think so. I think it's one of those frustrating things for families, because it really is a hurry up and wait kind of situation, right? We need to get to the diagnosis quickly, as quickly as we can, to make sure that the child is safe, you know, particularly from things like a respiratory standpoint. But then it takes a while for all the tests to come back, and sometimes we need follow-up imaging. And so I think it can be frustrating for families, and I think being very transparent about that is really important.